Accelerator BNCT in Japan. So let me introduce myself briefly. As Dr. Hu said, I am originally from Osaka. I think you know something about Japan. Here is Osaka, and here is Tokyo. And I am originally from Osaka and graduated from Kyoto University. And I was working at National Cancer Center East and to learn about clinical trials, and I had a lot of experience of doing proton beam therapy. And after that, I moved to Tokyo Metropolitan Komagome Hospital, and I was in charge of introduction of high precision radiation therapy machines and its expansion of clinical indication. And finally, 5 years ago, I moved back to Osaka, and I got involved in BNCT. And this is Osaka area. Here is Osaka, here is Kyoto. Our university is located around here. Kyoto is here, Osaka is here. It's very convenient to visit both Kyoto and Osaka. So please, you are welcome to visit our institution. So at first, I'd like to show you the ASTRO annual meeting. This is the website of ASTRO annual meeting this year. It was held in at Washington, D.C. This September. And you can check the contents of ASTRO meeting through the social media such as X, Twitter, or Facebook, Instagram. And this is the biggest society for radiation oncology, and more than approximately 10,000 participants from 78 countries. And there were more than 2,000 abstracts, and 181 companies exhibited their devices or machines. And I had a chance to give a lecture on BNCT at the Industry Expert Theater during the meeting. These photos show the exhibition hall, which was very huge area, as you can see. And at the corner of the exhibition hall, there is an Industry Expert Theater like this. Its capacity was around 120 or 30. And in my expert theater, around 60 visitors participated. And after my lecture, there was a questionnaire, and these are the results of questionnaire. Correct rate was 52%, and most participants were from United States, and most of them were physicians or medical physicists. And they had an impression about BNCT, excellent or good. And they got very interested in BNCT, but they thought they need more information about BNCT. And there is the other presentation, the poster presentation by Dr. Takeno. He is one of my colleagues, and his presentation title was 2 years of clinical experience with accelerator-based BNCT for head and neck cancer. There were only 2 presentations in this meeting about BNCT. One is my lecture, and the other one is his poster presentation. So I recommend you submit your results of research to these meetings. And this is the photo spot of the meeting. And I appreciate Sumitomo Heavy Industries and my colleagues. From now, I will show you the presentation I gave in that meeting. There are contents. What is BNCT? History of BNCT. BNCT for recurrent head and neck cancers. Comparison with X-ray therapy. And finally, problems and future perspectives. What is BNCT? Most participants today know about BNCT. BNCT means boron neutron capture therapy. And there are very important keywords: cell selectivity, microscopic view, and both internal and external radiation therapy. You will understand these three keywords after my lecture. And here is the mechanism of BNCT. The red circle shows one tumor cell. And you can see here the boron atom. And if you irradiate the neutron beam like this, there occurs nucleus division and dividing into two heavy ion particles. One is alpha particle, the other one is lithium nucleus. And their ranges are less than a cell diameter, so they cannot go beyond this cell and can damage only this tumor cell and never affect the normal cell next to this tumor cell. But we don't have boron atoms in my nature body, so we have to use a boron agent to deliver boron atoms to the tumor cells. We use BPA, boron phenylalanine, as a boron agent. The tumor cell can accumulate these amino acids to proliferate. So BPA can easily accumulate to the tumor cells. And these reactions occurs in tumor cells. But the mechanism is not that simple. There are other reactions between neutrons and other atoms like nitrogens and hydrogen, and some radiation dose occurs, but most dose of BNCT consists of boron dose like this. But there is a big difference between the tumor dose and normal cell dose. That's because the BNCT is effective to the tumor. And here I show you the typical dose distribution of photon or proton. As you can see, we can prescribe the dose to the tumor, and there is an excellent dose concentration to the tumor, but extended low dose area in the normal tissues occurs that causes the limitation of total prescription dose by these treatments. And this is a dose distribution of BNCT. You can see the gross tumor volume in red here. And in the tumor volume, there are 40 gray, 30 gray high dose area. And just outside the GTV, very low dose area, you can see 5 gray, 4 gray. And there is a steep dose gradient on the border between the tumor and the normal tissues. But this is just macroscopic view. We have to change our mind from macroscopic to microscopic. The difference of the dose occurs microscopically in BNCT. So if there are some tumor cells outside the GTV around here, if microscopic tumor cells outside the GTV, if boron agents are taken, they can receive sufficient high dose like this. And this slide shows how BNCT is a highly selective treatment. And this patient received BNCT and had a chance to receive a surgical biopsy after BNCT. The area A shows a tumor site, and the area B shows parotid gland. And in pathological findings, in the area A, you can observe the scar tissue, and there is no tumor cells. And that means BNCT was effective for this patient. And in the area B, the parotid tissue showed almost no damage, and there is a normal structure of the parotid gland. So how highly selective treatment BNCT is. So BNCT can selectively damage the tumor cells and give little damage to the normal cells, and can treat recurrent tumor after receiving external beam radiation therapy, and can be effective for radio-resistant tumors or multifocal tumors. And now BNCT is a one-day treatment, is a short course treatment. It's convenient for patients. Next, I'll show you the history of BNCT briefly. Most participants today know about BNCT and some history about BNCT. So I will show important 3 points of breakthrough in development of BNCT. One is the development of boronophenylalanine, BPA. Dr. Mishima developed BPA, and he treated the first patient with malignant melanoma using BPA. And the treatment was very successful. And the second breakthrough is modeling of reactor facility to utilize epithermal neutrons. Here I show you the figures of flux of thermal neutron and epithermal neutron. Red curve indicates a thermal neutron. Green dot lines indicates epithermal neutron. And if we can use epithermal neutron, the tumor from surface to the deep-sided tumor can receive neutron beam effectively, as you can see. So this is the second breakthrough. And in 2001, the first BNCT for recurrent head and neck cancer in Kyoto University reactor was done. But reactor is like this, very big facility, and it is just an experimental facility, so it cannot be prevailing. So we have to develop some other type of neutron source. So in 2007, the project of development of Accelerator BNCT system started. And in 2008, first Accelerator system was settled in Kyoto University reactor. This is the Accelerator Sumitomo Heavy Industry developed. It's very small size, very convenient, and it can be prevailing. And after that, we conducted some clinical trials for recurrent malignant glioma and recurrent head and neck cancers. And as you know, in 2020, finally, BNCT for unresectable, locally advanced, or locally recurrent head and neck cancers was approved as health insurance treatment. So you can understand 3 points of breakthrough in development of BNCT. So in these 5 years, we have been treating patients with recurrent head and neck cancers by BNCT. So I'll show you some data of these data. First, clinical trial before approval, and retrospective data from our center after approval, and real-world data from post-marketing surveillance. And this is a phase 2 trial of Accelerator-based BNCT for recurrent head and neck cancers. It was conducted in Fukushima, Southern Tohoku BNCT Research Center between 2016 and 2018. And 21 patients were accrued, and complete response rate was 24%, and partial response rate was 48%. And finally, the primary endpoint of overall response ratio was 71%. That was very excellent for recurrent head and neck cancers. So because of that results, BNCT for head and neck cancers was approved as health insurance treatment in 2020. Its medical fee was $15,900 for irradiation and $3,000 for 1 pack of boron drug. And now there are 2 institutions doing health insurance BNCT. One is my center, and the other one is Southern Tohoku BNCT Research Center. Next, I'll show you the retrospective data from our center. These data was presented by Dr. Takeno at the ASTRO annual meeting this year. We treated 69 patients between 2020 and 2022, 43 male and 26 female, with a median follow-up period of 17 months. Most of them already received surgery or radiation therapy or other chemotherapy. And treatment system we used is NuCure BNCT system by Sumitomo Heavy Industries, and boron compound was stebronin by Stella Pharma. And planning system is Ray Station with NuCure dose engine by Sumitomo. And as you know, the dose limiting factor is defined as skin, the normal tissue dose, skin up to 15 gray, mucosa up to 12 gray, brain up to 9 gray, eye up to 5 gray. And this is the overall response rate, 80.5% achieved. This is very good results, the same as that of clinical trial. And adverse event was acceptable. Here I show you the one case of nasopharyngeal cancer treated by BNCT in our center. She was 40-year-old female, and she received at first standard radiation therapy with a total dose of 70 gray in 35 fractions, but unfortunately, the tumor didn't respond like this before the radiation therapy. After radiation therapy, the tumor remains. And she received BNCT after that. And 1 month after BNCT, the tumor started to shrink. And 6 months after BNCT, the tumor completely disappeared. So BNCT is effective even in radiotherapy-resistant tumors as long as boron accumulates. And this is real-world outcomes from nationwide post-marketing surveillance in Japan. This data has already been published as a paper, so I'd like you to check the original paper so I can show you this data briefly. These data are from our center and Southern Tohoku BNCT Research Center. 162 treatment cases were analyzed in safety, and 155 cases was analyzed for the efficacy. And I'd like to skip this slide. And this slide shows the acute and late adverse effect. Acute adverse effect were just temporary, and late adverse effect were acceptable. And the overall response rate was 72.3% in squamous cell carcinoma and 64.7% in non-squamous cell carcinoma. So the data from this post-marketing surveillance, the overall response rate was again excellent. So in summary, BNCT for recurrent head and neck cancers achieved excellent response rate with acceptable toxicities in our retrospective study and also post-marketing surveillance. And if surgery or standard radiotherapy is not feasible, BNCT should be positively considered in earlier disease stages. Okay, from now I'll show you, I will explain the problems and future perspectives comparing BNCT with X-ray treatment. Dose setting in X-ray treatment is shown here. IMRT can achieve an ideal dose distribution by controlling the doses to both normal tissues and tumors. So we can prescribe the dose to the tumor actively and control the dose to the normal tissues in X-ray treatment. So in X-ray treatment, relation between dose and efficacy in tumors and also between dose and toxicity in normal tissues have been elucidated already. And I think X-ray treatment is almost matured. But there are some problems in BNCT. In dose setting in BNCT, it is defined as the tolerance dose to the normal tissues, as I said before. The skin dose is set as up to 15 gray, mucosa up to 12 gray. So if the mucosa dose is up to 12 gray, like this, we have to check how much dose can be delivered to the tumors. In this case, the tumor can receive almost more than 20 gray, as you can see here. So the tumor dose is defined D80, more than 20 gray is regarded as eligible for BNCT. But as you can see in this graph, in the area of more than 20 gray, the tumor dose differs in every case. So the tumor dose cannot be actively defined in BNCT, but it's defined by the normal tissue dose. So there occurs uncertainties in tumor doses in BNCT. It's a big difference from X-ray treatment, and it's a big problem in BNCT. So the tumor dose in BNCT depends on boron concentration, neutron dose, and CBE, compound biological effectiveness. And the boron concentration is calculated using the TN ratio, tumor normal tissue ratio, obtained just by experiments. And we use only one value of TN ratio for every patient. But more accurate detection of boron concentration for individual patient is needed to calculate more precise dose to the tumor. So we expect FBPA PET for future possibilities. So we use BPA in BNCT, and FBPA can be used as an agent for PET imaging. These three drugs are similar, had similar pharmacokinetics and accumulating highly in tumor cells. And we can possibly estimate the boron concentration by using FBPA PET imaging like this. You can see the FBPA accumulation to the tumor site. And in this patient, TN ratio was calculated 10.1 and not 2.5 we usually use. So we can estimate the tumor dose for individual patient like this. If we can estimate the boron concentration, we can elucidate the dose-response relationship between tumor and also we can elucidate the dose-response relationship between those and normal tissues. And if we can resolve these problems, BNCT can make a big progress in the future, because there is already mature data about X-ray treatment. All the knowledge and expertise are accumulated in X-ray treatment can be utilized in BNCT. So BNCT can make a big progress. So I've just shown you the problem from biological aspect, and there are some other problems. One is the utilization of neutron beams from physics aspect. We have to shorten the irradiation time. And if we can shorten the irradiation time, the diverse irradiation technique, we can use various types of irradiation technique. This is a neutron beam. The neutron beam is goes like steam, goes like fog, like this, out of the irradiation hole. So it is very hard to control neutron beam. So if we want to use neutron beam efficiently, the gap between the patient and the irradiation hole should be closer. And the gap between the tumor and the irradiation hole closer, the flux of neutron, stronger the flux of the neutron, as you can see in this figure. Now we use only one port in BNCT. And there is a tumor here, and we irradiate the neutron beam from here. But there remains those deficit on the opposite side of the beam. And if you irradiate neutron beam from the other side, also those deficit occurs on opposite side of the beam. But if we can use two fields technique in BNCT, those coverage in the tumor improved. And finally, there is a big problem from clinical aspect. We have to expand the insurance coverage treatment for other diseases than head and neck cancer. I'll show you some clinical trials for other diseases. This is a phase 2 trial of Accelerator-based BNCT for recurrent malignant glioma. And the primary endpoint was 1-year survival rate. And the result of the primary endpoint was 79.2%. And the median overall survival was 18.9 months. These figures are excellent compared with other data from historical papers. But because this trial was just a phase 2 trial, so we couldn't show the statistical significance, superiority of BNCT. So BNCT for malignant glioma has not been approved, unfortunately. And here I show you the randomized phase 2 trial of Accelerator-based BNCT for recurrent high-grade meningioma. And we have conducted a randomized trial, phase 2 trial, but randomized trial. And patients with high-grade meningioma after radiation therapy were randomized either to BNCT or to best supportive care, 2 by 1. And this trial is ongoing, but patient accrual was finished, and now we are analyzing the final data. So if the data is good, we will move on to the application for approval. So I hope BNCT for recurrent high-grade meningioma will be approved in 2 or 3 years. And there are other clinical trials in BNCT, and one is a clinical trial for unresectable skin cancer and angiosarcoma, conducting in at National Cancer Center Hospital. And there is a pilot study for recurrent breast cancer after radiation therapy at Edogawa Hospital. And these two hospitals have another type of accelerator than Sumitomo machines. And there is another clinical trial of BNCT as a boost for primary malignant glioma being conducted in Tsukuba University. They also have an original accelerator. And there are some types of accelerators in Japan. Green one is an accelerator from Sumitomo, approved by government. And this one is installed in National Cancer Center and Edogawa Hospital, another type of accelerator. And this is Tsukuba, and here this is Shonan Kamakura Hospital. So we should do clinical trials for each diseases from phase 1 to phase 3, but it's also there are different types of accelerators, so should they be individually approved? It's very time consuming and it demands more manpower and it costs too much money, you know? And international trial or basket trial. Basket trial means transversely including various types of diseases. This trial might solve these problems. Well, anyway, it's the biggest challenge from a clinical aspect to expand the clinical indication of BNCT. So, closing remarks. This is the same slide as I showed you, and you can understand what BNCT is, and also you can understand these 3 words, what these 3 words mean. Now, around the world, there are some types of BNCT research or clinical research in BNCT. And especially in Asian countries, they are in China or in Korea, they are doing some clinical trials with using their own machines. And there are some relevant academic societies in the world. One is JSNCT, Japanese Society of Neutron Capture Therapy, which was organized in 2003. And the Congress is held annually. And this year, in July, actually, I was an organizer of the Congress, and it is held in Osaka. This is a flyer of the Congress. And I defined the theme of the Congress as integration of research for patients, because we are doing insurance-covered treatment in Japan. around 300 people participating in this Congress. Next year, it will be held in Nagasaki, so you can come to Nagasaki. And of course, there is an International Society for Neutron Capture Therapy. It was started in 1983. 1983. And its Congress is held every 2 years. And this year it was held in Krakow, Poland. And 2 years later, it will be in Argentina, 4 years later in China. So you can go everywhere in the world if you become a member of the ISNCT. And how about the other organizations? In PTCOG, Particle Therapy Cooperative Group, in 2022, BNCT subcommittee was organized, and some members in the ISNCT are the members of this subcommittee. But in ASTRO, American Society for Radiation Oncology, and in ASTRO, European Society for Radiation Oncology, I think there is no BNCT committee. And there are in these meetings, there are most sessions are clinical sessions, but there are some other types of sessions like biology sessions, medical physics sessions, basic research sessions. There are some other types of sessions, so you can submit your research results to these bigger congress. And I think we have to help other researchers recognize and understand how BNCT is an effective treatment as a cancer treatment. So BNCT is very interdisciplinary. So as I said, participation and commitment of radiation oncologists, not only radiation oncologists, but also medical physicists and technologists, pharmaceutical scientists, chemists, biologists, engineers, all relevant people should participate, commit to further development of BNCT. So I believe BNCT is the next authentic hero. And finally, I appreciate daily support of Sumitomo Heavy Industries and our colleagues from the Department of Radiation Oncology and our BNCT Center. And also I appreciate Professor Koji Ono. He is one of the BNCT pioneers in Japan. He is actually supporting us every day, and I respect him. He is actually the most high-spirited person in my center. So thank you for your attention. That's all for me.
Thank you so much, Keiji, for this spectacular presentation. Thank you very, very much for your time, for sharing these results and your experience in ASTRO. I think it's very, very important.